Care Derbyshire. I've been asked to, you're supposed to give your thumbs up, but I don't know how many people that is. We're seeing a few coming up now. Oh, quite a few, that's good. Okay, well, Joined Up Care Derbyshire is the name we give to the integrated care system in Derbyshire. Lots of other places just call it the Nottinghamshire ICS. We call it the Joined Up Care Derbyshire to reflect that. This next slide shows the organisations who are involved, and they primarily consist of the local authorities and also the statutory organisations delivering care. Can I say that there are a lot of other organisations that are a really important part of the whole process? I'm thinking particularly here of the voluntary sector. Working closely with the voluntary sector is absolutely critical in terms of providing integrated care. There's going to be there are a wider range of other organisations as well. So the ones who are listed here are very much, if you like, the statutory ones under the NHS or within the local authorities. But I don't think we should be thinking that these are the only organisations who we're going to be working with. And in some, I mentioned the voluntary sector, Rolls-Royce is another organisation who, as we work with the local authorities, try to improve the health of the population. Those organisations such as Rolls-Royce have an important role to play as well. Thank you. Can we move on? The journey officially in terms of when all this began started back about 5-6 years ago now with STPs, or Sustainability and Transformation Partnerships. In practice, though, we have been working closely with social care and others long before this. So it's not totally new. What I think is very much welcomed is a real focus on collaboration and integration, and less on trying to operate as a market. And I think that's something that many people across the health and care system warmly welcome. We've submitted plans as early as 2016, have refreshed those later on in response to the NHS plan. We were officially designated an ICS as opposed to an SDP this year, and as I said, in April 2022, all ICSs will become statutory bodies, and we may well come back to that in discussions. Next slide, please. As I said, this isn't a new way of working, and it is going to be building on a lot of what we've already done. I think, though, we need to recognise there's a long way to go. We hear from patients and from people in the communities that, from their perspective, our services are still not integrated. There's still quite a lot of fragmented services as you move from one part of the system to another part of the system, as you move from hospital into the community. And so there's a huge amount of work we still need to do to provide people with a single service as far as they're concerned, not a range of services from different organisations. Thank you. Next slide, David. The focus is very much broader than just a treatment service. The NHS has, I think, for a long time been a treatment service. We're seeing ourselves having a much wider role than that, the health of the population. And that's the importance of working with a really wide range of organisations and of people. Because if we are going to address the determinants of ill health, such as lifestyle, housing, employment, then the NHS has a really important role to play in that. In terms of, we employ a lot of people, we also spend quite a lot of money. So can we, through those, use it in a way which really adds value in terms of improving the health of the population? So it's not just about delivering integrated care, which improves people's health, which makes like what's their opportunities like, much more than just the treatment service. So we do recognise that traditionally the NHS is focused on the 20%. We need also now to work with others on the other 80%. I've said that an integrated service, I've mentioned the statutory organisations involved. This picks up some of the other areas. And if you think about the wider determinants of health, then you'll see why these are a really wide range of organisations and people and sectors across Derbyshire. I've mentioned the voluntary sector before, but the police, the fire, in fact, the fire service is a really good example where they moved a number of years ago to yes, putting out fires and saving people, but also of being an advisory service to stop fires and to reduce the number of fires. And that's been really successful. So that's a really good example of what how the NHS wants to shift. Not that we don't treat people, but we also help people to live healthy lives. As I mentioned, we're going to become a legal entity from April 22. The legislation should be going through Parliament, I think July onwards. And the really good thing there is the focus on collaboration, as I've said. Next slide, thanks. So why is it so important? I think it's so important because we hear from patients that they feel that care is fragmented. So when someone leaves hospital, then are we sure that they've got the care in the community, the social care support, the housing arrangements that's appropriate for them? When people are, if you've got a mental health, if you're struggling with your mental health, very often people also are struggling with other challenges, physical as well as mental health. Are we joining those up? Are we making sure that we're looking at the patient as a whole and bringing all our care and all our attention, all our support, and not just having different professionals coming in at different times, often repeating the discussions and looking in quite a narrow way. So that's, we've heard a lot from patients and from the public about the fragmented nature of some of the services. Patients do fall in between the gaps, and those are the sorts of things we've got to stop happening. And so the real focus is it's important because we think it'll give much better care, but also it'll be a chance for us to support those people in terms of living healthier lives and not getting sick so much and not needing to come to hospital or see their GP. So it's very much the patients at the centre. By coordinating things, integrating things, we're able to work much more efficiently and much more design the delivery of services around what those patients and what those people need. Okay, well, that's a sort of brief introduction from me. Chris is now going to take over and take you through some of the detail that's behind those very high headlines that I mentioned. Thank you.
Thanks, John, and thanks to everybody for joining us. My name's Chris Clayton, for those that don't know me, and I'm the executive lead for Joined Up Care Derbyshire, and substantively I'm also the accountable officer for Derby and Derbyshire Clinical Commissioning Group. So good to see you all. My internet connection, probably like many of yours, is a little bit unsteady this morning. So if my camera goes on and off, please don't be alarmed. I'm still here, and I'll do my best to keep talking us through the slide deck. Whilst I've been watching the chat box so far, but whilst I'm talking through the slides, I'll pay attention to this. So colleagues are going to help us towards the end and work through some of the questions that are coming through. So essentially, just to remind ourselves, and thanks to John taking us through, Joined Up Care Derbyshire is our integrated care system. It's what we've been building for many years now, and essentially it is the health and care system for Derby and Derbyshire. It covers the NHS and also public health within that health boundary. But it also includes mainly our social care inputs for both children and adults, and so it does cover all ages. In terms of the point of it, what is it here to do? Well, essentially, it's in the title of this slide. It is there to improve life expectancy and increase healthy life expectancy, and I'll talk you through those in the next couple of slides. I mean, that's its prime purpose. That's what we're here to do, and that's what the partnership of health and care have decided that they want to focus on. And the reason for doing that is because in many areas, some of our outcomes in terms of life expectancy and healthy life expectancy aren't what we want them to be. There's this slide we've pinched from Dean Wallace, who's Director of Public Health and part of the partnership, and it just starts to say, look, we've got to look at all ages in the full spectrum of life, because there's there's things to develop in all of those ages. Clearly, the health needs of children are different to those at the end of their life. But the point is, we've got to focus on all aspects. And there are some big areas on the health and care side that we want to work on particularly. And if you think from a health and care point of view, well, clearly there's a lot of urgent care needs that we have. And as you know, we focus particularly on our accident emergency departments and other urgent care services that we offer. Clearly, we've had a significant impact from the COVID-19 pandemic into that urgent care system, but also there are other conditions that contribute there. Obviously, cancer and some of our more planned services are less urgent services such as orthopedic operations and so on is a very significant area for us, as is mental health and learning disability. So you can see that we've got lots to work on. In the slides that follow, and if I could go to the next slide, David, I'd be grateful. Thank you. In the slides that follow, and there's one coming up in a couple, where I just talk about what impacts the overall outcomes on health. I'll set out the differences between what's in our control as a health and care system and what we need to work in partnership with, as John was setting out. But on this slide, it's just a very good visual, and again, thanks to our county council colleagues who've put this together for us, that just sets out the difference between life expectancy and healthy life expectancy. So in very simple terms, life expectancy is how long we expect to live for, and as you can see, there's a difference in that profile between men and women. That's been a long-standing feature, but you can see there is a difference. There's not only a difference between men and women, there's actually a difference in how long you live between different parts of the city and county. It's not a universal figure for everyone, is life expectancy. And that's something we need to really focus on. And similarly, this concept of healthy life expectancy. So if we, for example, live for 80 years, if we're going to live for 80 years, then how many of those 80 years do you live in good health? And how many of those years do you live with less than good health and sometimes poor health? And that healthy life expectancy is the time from birth up until the point where conditions start to accumulate and people start to experience less good health. I mean, a really good example of that is cancer. If we take cancer, thankfully more people live with their diagnosis of cancer than they did many years ago. And so actually lots of people are now living with cancer as a long-term condition. And so our role now is thinking about how do we increase the amount of time that we all experience a healthy life expectancy. And I hope that makes sense. I'll keep talking about it. Obviously, I'll take any questions as we go forward. Oh, thank you, David. You preempted me. Thank you. In terms of both the healthy life expectancy and overall life expectancy, there are some big health conditions that are causing those poorer outcomes than we would like. Number one still remains cardiovascular disease, so heart diseases and stroke. That is our number one priority, but there are others as well. So we think about chest disease, respiratory disease, asthma, chronic obstructive pulmonary disease, what used to be called chronic bronchitis and emphysema. Those are significant conditions. Cancer, of course, and you can get lung-related cancers, as we know, but that is a big cause of of ill health and unfortunately still early premature death for some people in our population. But when we get to things like musculoskeletal disease, our joint diseases, like back pain, they are causing a significant impact on that healthy life expectancy. And particularly another good example of that is mental health, and that can mental ill health can cause a significant disability for some people in our population, and so it's a really important set of conditions to consider. So I was just talking earlier about what are the things that determine those overall health outcomes, those life expectancy and that healthy life expectancy. Well, I refer to this slide as Dean's slide. So again, another one I've pinched from Dean Wallace, Director of Public Health of the county, and it's a really good slide that I think he took from another source that sets out what are the things that contribute to those overall outcomes. And as you can see from the slide, it isn't just the work of the NHS. It isn't just the work of the care sector. As you can see here, there are many different contributors to these. So if we think about direct clinical care, so the direct work the NHS does, actually in the broad scheme of things, it contributes about 20% to somebody's overall outcomes. And as you can see, education, housing, the environment people live in, their wealth, also contributes to varying degrees. Being a half full person, if we think about Joined Up Care Derbyshire as the health, including NHS and public health and social care system, and you just do a quick calculation adding the percentages up there, from a Joined Up Care Derbyshire perspective, in terms of the statutory agencies, we've got about 50% opportunity in that partnership to directly influence some of these things. But actually there's 50% that are influenced elsewhere. And so, as John was describing, Joined Up Care Derbyshire as an integrated care system is going to be important, but it's not going to be everything to those overall outcomes that we're trying to improve. And so we're going to have to work in partnership with lots of different agencies and people to improve those overall life expectancy figures and healthy life expectancy figures. So thank you. David's well ahead of me now, which is great. In terms of, well, how are we going to do it? So if we take that 20% of clinical care that we're really used to on the NHS and social care side, then we're clearly creating a model of care. And there are lots of different facets that make the model of care. And as people, as patients ourselves, we interface and interact with all of these different elements. So clearly, one of the most important elements is that we look after our own health, and we all have a responsibility to look after ourselves, and take measures that keep us as healthy. I know that's not always easy to do, but there is something about self-care, preventing illness in the first place, and one of our big roles is going to be helping us all to do that. Sometimes though, we need care, and we need further services to help us with some of those things, and clearly the community is our first port of call in many instances. And actually most of the care happens in our local communities, either in our GP services, our social care services, our district nursing, and so on. Most of the care, about 70%, actually happens in the communities in which we live. Obviously, though, there are some times where we need specialist support, and our hospitals are places that we know well and really appreciate the care that they deliver, both in general hospital care in our district general hospitals, but also very specialist centres that we have sometimes for those very specialist care needs that we have. And of course, if we've been in hospital, we need every help that we can and support to come out of hospital and get back to where we were before. So that's a really important part of the model of care. So I hope that's helpful, brief descriptor. Just want to talk, if I may, just for a moment on um, this concept that you may have heard of or you may not, but I'll talk you through it in terms of the anchor institution approach. So if I take you back to Dean's slide where it talked about those wider determinants of health, then as Joined Up Care Derbyshire, we're thinking, well, how do we influence those? How do we do that? How do we work in partnership? And one of the ways that we want to influence those wider determinants of health is by acting together, not just in terms of the services we deliver, but that wider contribution we can make by the sheer scale of the health and care system. So, I mean, we all know, don't we, that the NHS is one of the biggest employers in the world in terms of the scale of the organisation, not just the UK. It is one of the biggest employers, and if we add to that partnership the employment scale of social care, including our independent providers of social care, our public health sector, and so on, and we link with other big public sector institutions like the local authorities in a broader way, then instantly the reach of Joined Up Care Derbyshire and the partnership is really significant. And if we start to act in a uniform way, in a coordinated way, we can make a real difference on these 5 things that we've started to think about ourselves. As if we act in unison, we could make a difference in, working more coherently and cohesively with local partners. What can we do to help the well-being of our own staff, because our reach is significant. We employ thousands of people. If we make a big difference there, and those networks of staff can make a huge difference. If the money that we spend that's given to us through government, if we start to spend more of that locally in the local economy, what can that do as a contribution to some of those wider determinants? And as you can imagine, we have a significant impact on the environment due to the scale of the operations that we do. What could we do more in terms of just by working together in a coherent way? And that's the anchor institution approach. But you can see here on this this slide some of the opportunities that I've just referenced. But that's one of the elements in which we can influence some of those wider determinants of health. And if I could have the next slide, please, Dave, I'd be grateful. Thank you. Now, clearly, Joined Up Care Derbyshire, if you think about the NHS and the scale of the NHS, the social care side of local authorities, and you think about public health, you think about the number of interactions between clinical practitioners and professionals and people. You think about the multiple different organisations that bring that together. It is a complicated and it is a complex thing. It isn't just one simple structure to put together. It's a multitude. It's thousands and thousands of interactions on a daily basis that are happening. And so if you think about that, the structure of the integrated care system will not be a simple one. It is complex. It is complicated. Our job is to make it less so. And by bringing the partners together, we want to make it less so. But it is inherently complex and complicated. But it has got some simple principles that we're trying to do and trying to work against. And we've put them on a slide here. We're not going to put up the organisational structure chart for Joined Up Care Derbyshire. That's for myself and other colleagues to work through. But hopefully this is a straightforward messages about what we want to do. So in the centre there, you've got the Joined Up Care Derbyshire board in blue, and that's the representative body of the health and social care system. Well, there are 3 key things that we need that board to be driven by and to be influenced by. Now, one of them at the top, and these are in no order because they're all important, is about strategic intent. So the board and Joined Up Care Derbyshire has got to be advised on what are the things we need to do to improve life expectancy and healthy life expectancy? What are the things that are going to work? What are the causes, and where do we need to act together on? And so we're pulling together this strategic intent concept and vehicle for the system to really help us all work on it. Now, clearly the NHS and social care and public health have all been working in a strategic way for years and years and years. The difference here is that we're wanting to do it together and to bring those thoughts together and that strategy together. Clearly, though, as I said earlier, if you add together the resources of the health and care system, we have a lot of assets. We have a lot of things that we need to work on together and best use. So if you think about the money that is allocated to Derby and Derbyshire for those services, it's a lot of money. So we've got to make sure we use it in the most effective way. Equally, we employ thousands and thousands of people, and we need to make sure that we look after that most important asset very carefully, and equally help it to be the most effective deliverer of care that we can. Clearly, I can see some brief comments in the chat around estates. We have a lot of estates that we need to get the best value of them. So Joint Care Derbyshire really does need to use its assets very, very carefully. But then on the right, I think I'm hoping I've made the case that if we just stay as the NHS or social care or public health working in an isolated way, we're not going to get very far. So Joint Care Derbyshire needs to really work through partnership. It has to work through partnership with other agencies. John started to mention others like the fire service, like police, who've got a real contribution to make as we have. And so we're not going to get very far unless we really work in strategic partnership. And thank you. So this is the sort of most straightforward. I told you it was a complex structure chart. This is one of the most simple ones. Like I say, my job is to pull all of this together, but hopefully it shows you how in the center bubble you've got there in blue the integrated care system, but it just shows you the many connections that are made within that bubble. And so round the edge, you've got the primary care networks that we've got. We've got 15 for Derby and Derbyshire. They're the networks of general practices that come together in more local communities to bring together general practice and community services. Those are connected at a higher level through our place alliances. And those are connected again to the county and city places that we have in Derby and Derbyshire. And you can see there are other things that we need to connect in the partnership. So I'll just show, hopefully that shows how we move up and down between an integrated care system board at one end and care delivery in the community to those who need it at the other. And it's a flow between the two. It's not an up and down. It's not a hierarchy. It's a flow between, and that's the importance of it. And if I could take the next slide, David, thank you. In terms of the board, so as John says, it is clear now that the government wishes to legislate and bring about integrated care systems more formally onto the statute books. They're currently an informal partnership, and we've done a lot through that informal partnership, but the government has through its white paper is intending to formalise them, and it will do two things as we see it now. As we understand it, will create a formal integrated care system NHS body. So there will be an NHS body that brings together all the different NHS agencies that we have under one banner, and that'll be called the Integrated Care System NHS Board. And it will also set out in statute that broader partnership that I've been talking about for the last few minutes about the NHS with other aspects of health, public health and social care into a broader partnership board. So we're really well placed to take advantage of anything that comes through formally on the statute books there. But the NHS board, as you know, has a few specific statutory areas that David's just shown you, and again, similarly, that broader partnership board will ultimately their role will be to improve the outcomes that I set out earlier. That those will be the statutory duties by working in partnership, by creating a strategic view as to how we're going to improve those by the use of our assets and by effective partnership. So I hope that's helpful, and I'll take the next slide. Thank you. So as I was saying, we're equally not going to get very far if we think that we can run the health and social care system from a central board in, you know, either located in some point in Derby and Derbyshire. We're not. Most of the care, as I said, 70% of the care is actually delivered in the communities where people live, and that's true. But they need to be helped and supported through the work of the integrated care system. And so something that's really important to us, it's been important to us for many years now and been building the model, is the concept of place partnerships. And that still is an inherent and important building block of Joined Up Care Derbyshire. It really is super important. And through the work of colleagues over the past few years and more recently, we've established two very important structural place partnerships, one at the county level, one at the city level. But underneath those are really important structures that help deliver care closer to where people live in the place alliances. As you know, we've got 8 of those, and those primary care networks, and we've got 15 of those. That's where true joined up care will happen. That is where it will occur, and that's what we need to get behind and support. But equally, it's also true that those structures will need support from the integrated care system to help that alignment and support them. And if I could have the next slide, please, David, I'd be grateful. Thank you. Now, this is something that you may or may not have heard of before. So I think the concept of place isn't new to us. But in the NHS particularly, a new concept has been described called provider collaboratives. Now, that's a technical term, but put more simply, it is about saying, look, in the NHS, you know, although it is one national health service, as we all know, there are lots of different parts that make that. We have hospitals, you know, and we don't just have one hospital for Derby and Derbyshire. We've got 2, and we've got hospitals around Derby and Derbyshire that our patients also go to. And, you know, we don't just have one service provider for mental health services. We have several. And so the concept around provider collaboratives is about bringing those different providers together, where there's a theme around them coming together to improve the service that they offer. And so we've got 4 collaboratives that we're working on at the moment as under Joined Up Care Derbyshire. We've got one around hospital services. You might hear that sometimes termed as acute services, but you know, in other language, we'd refer to it as hospital services. So our 2 big hospitals working together. We've got one around mental health services. We've got one around ambulance services and the 111 services, because, as you know, there's a lot of synergy between and a lot of work that they could do together. And then lastly, we've got some a collaborative working around general practice services, because we have, as you know, we have 115 practices working in Derbyshire. We've got DHU, Derbyshire Health United, providing out of hours general practice services. So that, again, similarly, what's the benefit that they could bring by working more closely together? And so that's the concept of provider collaboratives, and more to come on that in the future. I'm convinced that will really help us in the future as well. And I think I'm coming to the end of my slides shortly, but there's one partnership that we actually want to talk about in greater detail. We can't do it justice today, and so through the work of Miriam, Sean and David and Katie, we're going to be, with your permission, doing a future Derbyshire dialogue on this subject on its own. But what's the public partnership? So I've talked a lot about the structural partnership, you know, a lot bringing the agencies together, but again, it's another facet that we're not going to get very far if we don't have a public partnership. Now, we've all been doing our best in this regard for many years as individual organisations, but you know, what can we do in a better way as a formal collaborative? Where can we go? And so one of the important aspects in terms of the structure of Joined Up Care Derbyshire that I'm working on with the board now is what's the public partnership, and how does that you know fit into influence and drive the whole structure? And so that's why we, with your permission, we'll be coming back to do a further dialogue just to explore that in greater detail. And it's up for debate. It's up for grabs. It's we've got the current structures and ways of working that we have now, but you know we've got that to consider. And then I think, David, we're on to questions, and I'll be handing over to Katie and Miriam to guide us through the questions that have been coming through, and John and I and others will do our best to answer. Anything we can't answer, we'll make sure that we come back to and bring back to colleagues that have joined us. Thank you.
Thank you very much, Chris and John. We had a question submitted by Roger, but I think this also links into additional questions that have come in the chat box from Damien and Ruth. Perhaps Chris and John, if you both want to take this one. One is about geographical boundaries, in particular with the Glossop CCG and Greater Manchester ICS. And the second one is around how will healthcare for our patients, you did touch on this, when they move about between hospitals that are out of our area, how will we work together with other trusts in different areas? Thank you.
Do you want me to take that one, John?
Yeah, that's fine. Yeah, you go ahead, Chris.
Is that all right? Yes. And I did see, I couldn't read them, but I did see questions coming in the chat. So if I take the boundary first and just set that out, if that's okay, and then I'll talk about how do you work across boundaries, if that's all right. So yes, so they're as colleagues and participants on the call are aware, that there is a question being asked around the boundary for Joined Up Care Derbyshire, for the integrated care system for Derby and Derbyshire, and it links to the area of Glossop Dale. And the reason why it's a question is because the white paper that the government produced set out that in most circumstances the boundary of the integrated care system should mirror the boundary of what's known as the upper tier local authorities. Now, for us, our two upper tier local authorities are Derby City Council and Derbyshire County Council. Now, the truth, and it's a factual position, the boundary of Joined Up Care Derbyshire doesn't mirror the boundary of the county council, because principally the NHS services for the area of Glossop are part of the Greater Manchester boundary and not part of the Derby and Derbyshire boundary. So that's a factual position. The NHS specifically has worked in that way for many years, and has worked in the sense that the patients who live in the Glossop area do tend to use services that are aligned in that Manchester way. So the hospital services of Stockport and others, and that is also true. That's true. And so when the white paper was set out, one of the partners in Derbyshire asked the question about the alignment of the boundary, because the integrated care system is more than simply the hospital services that are delivered. It's much broader, as I've set out, and so reasonably they asked the question, and so we were asked by NHS England and Improvement, we as in Joined Up Care Derbyshire and principally the Clinical Commissioning Group for Derby and Derbyshire, to ask the stakeholders for the areas in Greater Manchester and also Derby and Derbyshire, their view on the boundary and their view. And so we held an engagement process a few weeks ago now, and put together a report that brought together the views. We weren't asked to make a recommendation. We weren't asked to take a view on it one way or the other. We were just asked to ask for views on the subject and set out some of the considerations that would need to be understood and thought through if the boundary remained the same or if it changed. And that's what we did. We agreed with the stakeholders the report that went back, and we set out that position. That a decision is going to be made on the boundary for Joined Up Care Derbyshire by the Secretary of State for Health. I'm not privy to what that decision will be, whether it stays as it is or it changes, and I can't give absolute certainty on this call when that decision will be made, because that matter is with the Secretary of State. I expect it will be as the bill goes through Parliament, we'll understand what the decision is about the boundary. But that's as much as I know in terms of the process and the reason it's come about. The question about working across boundaries, well, that's not new to us. So we work across boundaries now, and we work that's a common thing. So patients aren't tied to where they live for care. They, if they need specialist care, for example, they often move across boundaries, and we're used to working in that way. The ambulance service is a really good example. So EMAS will go up, technically will go up to that Glossop area, but doesn't go into it. That's covered by the Northwest Ambulance Service. But those two ambulance services work together and do go across the boundaries as they need to, based on the needs of patients at those specific moments. So again, it's less of a concern to me in terms of being able to work across boundaries, because we're well used to doing it, and whatever the boundary decision is, we'll continue to strengthen those cross-boundary arrangements. I hope that's helpful, Katie.
Thank you very much, Chris. We've had two questions from a gentleman called Chris, and they are: who is the lead officer responsible for making the integration happen within the local authority, Derbyshire County Council? And is there going to be any additional money in the county council to help this integration process work, and will it be ring-fenced? Thank you.
Yeah, can I? Chris is obviously from the ICS, the lead officer for this. Within the council, you would have heard from Chris just how wide-ranging this is. So there isn't one individual who's responsible, though you could argue that the chief execs are. On social care, for instance, we've got a couple of people, the two directors of social care, Helen Jones and for the county council, and Andy Smith for the city, and those two are leading on the social care aspects. But if you think about the breadth of the ranges, so for instance, if we are going to be working with the council on housing or on other aspects of the health of the population, one of the things that came up was about the one public sector estate. There will be different people leading on different parts of it. So if you're just talking about social care, it's very clear. If you're talking about some of the other aspects, it'll be the lead officers in the councils who are leading on those in the different areas.
Thank you very much. We had a question from Sue about, do we believe that the new integration of care system will be able to combat the stigma associated with personality disorders inherent in some health professionals, and will there be more transparency so that we can access outcomes in detail? We've also had a couple of further questions in the chat box, Chris and John, about mental health and as a priority, and I know you have touched on it, but I didn't know if you wanted to just go back to that and just add a bit more detail. Thank you.
Yeah, thank you. And yeah, I mean, mental health, learning disability and autism is a really key priority area for Joined Up Care Derbyshire. It has been in the past and it remains so now. So there will be a continuation of that as a priority area for us. I think the point is well made around the understanding of mental health and mental illness, and I think it's fair to say we've all of us got a long way to go, haven't we, in terms of improving the understanding of those conditions and the understanding for people who suffer, you know, with and from them. So I think it's a point well made. You know, will this help us more? Well, of course it will, but it doesn't just land and rest with Joined Up Care Derbyshire. It lands and rests with all of us, doesn't it? From us as citizens in being more understanding, and you know, between you know, our individual practitioners, the organisations they work for, and systems that bring those together. So I think it's a point well made about the importance of mental health and us improving our understanding of them.
Thank you very much, Chris. We've had a question from Alexandra. How will commissioning work at place or county level? I know you touched on this towards the end. Local authority commissioning and public health. The ICS place seems smoother than the councils, which are unitary authorities and have housing, etc. as well. So how will it all work together? Can it work together successfully? Thank you.
Yes, I'm happy to take that one if we can. I mean, you know, I make no apology. These things are complex and they are complicated, and so these partnerships are never easy. You have to work at them. All relationships need work, and we've made significant strides in partnership working across Derby and Derbyshire. It's not a new concept for us. It's been one that's been there for a long time. The question is how much can the Joined Up Care Derbyshire, the integrated care system approach, take us further? You know, so what can we build on, and what can we continue to develop? The truth is, the statutes and the legal changes will help, but in and of themselves they won't be enough, because we'll get more done through the partnership approach. I think that's universally true. So I think yes, you know, it's not straightforward. These structures are complex and complicated, but we've got a really good basis in Derby and Derbyshire to build on. So I remain confident. Thank
you very much, Chris. Lisa said, can we get health professionals to link in with eligible benefits? It's very overdue and poorly mapped. That it works well in the cancer pathway, but it doesn't seem to work as effectively in other care pathways. I don't know if we can take that here, Chris.
Yeah, I mean, happy to. I mean, one of the significant contributions of Joined Up Care Derbyshire as an approach is looking at the integration between the services and what we call service pathways, care pathways, and stopping thinking about somebody's care as individual points in time and points of service. And so, yeah, I think it's crucial. One of the partnerships that I didn't mention, possibly because of the broad range and audience we've got on the call, is the clinical and professional partnership. So if I were to show you the structure of Joined Up Care Derbyshire, you'll see a clinical and professional leadership structure. And that isn't just about a board. It isn't about the most senior clinical and professional leaders meeting once a month. It's about how do we make sure that Joined Up Care Derbyshire is led clinically and professionally? How do we make sense of some of those things that all of our professionals out there know could be better if we did things slightly differently? So, that could well be a conversation that we might want to have as a Derbyshire dialogue, Katie, with clinical and professional colleagues across the system about that element. So it could be another one we do in addition to the public partnership. We could do one outside of the inverted commas, normal leaders from a clinical and professional point of view, if there'd be an appetite.
Thank you very much, Chris. We've also had a question from Joanna. Could an integrated care system mean the removal of services from some hospitals if we're delivering everything at scale?
The answer to that is that what we want to do under this is we think there's considerable scope for people to be treated at home or to have their follow-up care treated at home. So in that case, we would be looking to support people at home. So it's not so much removing services from hospital as providing them in a different way. Elderly people we know often stay in hospital longer than they need because we need to get proper care, support care, social care, domestic care, etc. for people, so they can enable them to go home. They don't necessarily need to stay in hospital for clinical care. And of course, we know that staying in hospital too long reduces people's confidence, reduces their mobility. So these are the sorts of things that we want to see changing. We don't envisage that we're going to see significant shifts in services in terms of stopping providing services, but I hope that we'll be able to provide services in a much better way through working together than we currently do, and in a much more efficient way.
Thank you very much, John. We've had a couple of questions about the importance of housing and also the environment and working to a zero, as part of the climate change. I know we've talked about some of the risk factors, but I just wonder if you wanted to add anything about that. There are a couple of questions about the importance of thinking about housing and the climate when we're thinking about health inequalities.
I mean, I think that I saw that question. I think it's an absolutely valid question. The question that we need to ask as the NHS is how can we contribute to and support the wider local authority strategy? So, for instance, we do cause pollution. We have lots of traffic coming to hospital. We incinerate waste, etc. We dispose of things. So can we do things that reduce the impact on the environment of those sorts of things that makes a real contribution to what will be a much wider strategy? And I think that goes back to the Chris's comments about the anchor institution. One of the elements on the anchor institution was around pollution and climate change. And the NHS is a huge organisation, and we should be able to make a major contribution to those wider strategies.
Thank you. I'm going to take one last question. I'm very conscious. Thank you very much, Chris and John, that we've gone over, but I know we were a little bit late starting. It's question. There are quite a few questions about mental health, and one is around suicide prevention. And I know we've touched on mental health. I just wondered if you just wanted to add anything in relation to that work.
Yeah, I mean, that's a really important area, and each death is tragedy, isn't it? So I think I mentioned the mental health learning disability delivery board that we have. So as part of our structure, we have a delivery board that's sole focus is that, and clearly they have a spectrum of things to look at, from how do they support people before their condition becomes mental ill health. How do we get in there early and help people who've got challenges, to at the other end of the spectrum, looking after people with really, really complex and serious and severe mental illness, and that's part of it. And of course, suicide prevention is a really important part of that, because ultimately we want to prevent suicide. So yes, I hope that's helpful. And again, I think we did a dialogue a couple of months ago from a mental health perspective, but always, if there's a lot of questions, Katie, come in, you know, always happy to do another one with IFTI, Majid support and other colleagues, if that'd be useful.
Thank you very much, Chris. I am sorry, we're at the end of the session. I'm very aware that there are a lot of questions we've not covered, both in the chat and submitted questions. Again, I reiterate that we always answer them, and by next week the recording of this session and all those unanswered questions will have been made. I'd like to thank Chris and John for coming today, and as they've both said, clearly there is an appetite for people to know more, and looking at the questions, obviously it's very clear that people want to understand more about the integrated care system. So yes, we will be coming back to you with some further sessions, and we hope that you'll come on those and learn a bit more as we move through. The next session is on July the 22nd, and it is all that is medicines. So it's about waste, medicines order line. We're hoping to cover the flu vaccine and potential booster, who makes the decisions on expensive drugs. So again, I'd like to thank you all for coming. We'll tell you more about the next session and further sessions relating to the integrated care system. Again, John and Chris, thank you so much. I'm sure you're both very busy. Thank you so much for coming and joining us today, and we hope to see everybody again soon. Thank you again. Bye-bye.
Thanks, everybody. Thank you.
Thanks, everybody. And thank you, Isabel, as well. Thank you.